like to thank Quantum Genomics for this opportunity. It's not often in medicine we get a chance to investigate a product from what we call bench to bedside, and that is from basic research to clinical research. And hopefully we'll have more to report on this in the future. I'm going to discuss complicated and difficult to treat hypertension, not necessarily from a purely medical impact, but from the public health impact, how hypertension is the leading cause of cardiovascular death and disability. We hear a lot about lipids because of the PCSK9 inhibitors, which are very costly but very effective, and not as much about hypertension, but if you look at the burden of disease, hypertension is clearly as important, I think more important. Here are some of my disclosures. I consult with a variety of industry partners. I have no stock or ownership in any. So what's happened around the world is as societies have industrialized and developed, hypertension, as I mentioned, has now become the leading cause of cardiovascular death and disability. And despite the fact that we have a lot of antihypertensive agents, some counts say as many as 125, you're still looking at a proportion of patients who are uncontrolled and those who need 3 or more medications to control blood pressure, and even on those medicines may not be controlled. If an individual has blood pressure that's not controlled on 3 or more medications, they're often called treatment resistant. And those persons who have more severe forms of hypertension, the last bullet point, have an increase in target organ morbidity and mortality, and that includes heart attacks, strokes, heart failure, and chronic kidney disease. So there's a lot of interest in controlling this powerful and prevalent risk factor for public health reasons, and perhaps in better ways of controlling these more difficult to control antihypertensive patients. Here's a public health conundrum. If you look at this particular graph, on the left side we have non-Hispanic whites, which is the term of art used in the US data. On the right side we have non-Hispanic blacks, which is also the term of art. You see in both populations that top graph is all forms of cardiovascular disease. It's the highest cause of death when you include stroke with heart attacks. And from 2000, extrapolating out to 2014, we see a downward decrease in cardiovascular mortality. So these are death rates, these are hard endpoints. 2 or 3 main points. Compare with your eyes non-Hispanic black on the left versus non-Hispanic white. Just look at the top curve, which is all forms of cardiovascular disease. Again, these are death rates. These are not soft endpoints. This is not how you feel. This is not even a biomarker, not even a physical examination finding. This is death. The death rates for non-Hispanic blacks is exceedingly higher than that for non-Hispanic whites. The other thing I want to bring your attention to, if you look at the curves, and some of these data are now starting to come in for more later years, you're seeing a slowing or a plateauing of the cardiovascular death rates, and some data suggest there may even be an uptick in cardiovascular death, both for the non-Hispanic whites and the blacks. Again, higher rates in the blacks versus the whites, but in both populations, a slowing of the decrease, a plateauing, and perhaps even an uptick. Now, why would that be? Well, the population is aging, high sodium intake is prevalent, and obesity is increasing, and those then would be markers for an increase in risk. Salient to what we are doing with Ferdinand is that if you look at blood pressure control rates, the top green bar, extrapolating out to some of the latest data, the control rates aren't getting better. Again, the population is aging, high sodium increase, and high obesity rates. All of those portend that we're not doing as well with blood pressure control. So that leads me to the concept that there still is a reservoir of need for complicated, difficult to treat patients and patients with resistant hypertension, that only half of persons with high blood pressure are controlled, that it's more common in obese Black and minority populations, and that it may be driven by some pathophysiology, including salt sensitivity, low renin levels, sympathetic nervous system overreactivity. If you look at the guidelines on the third bullet, for both the US guidelines from the American College of Cardiology and American Heart Association, both of which I'm a fellow, and the European guidelines, both mention that in self-identified Black patients, there's less response to monotherapy with angiotensin-converting enzyme inhibitors and angiotensin receptor blockers, and a persistent need to treat resistant hypertension. The fourth bullet, if we identify an aging population, increased sodium intake, salt sensitivity, and obesity, that particular component of the poor blood pressure control is getting worse, from 30% 1999-2000 to almost 40% in some of the latest data. And the population that has poorly controlled blood pressure and increase in mortality, Blacks and Hispanics, almost half have obesity, much more so than whites. This prevalence of obesity then may be a direct factor since it increases the risk for resistant hypertension fivefold. The bar graph in the legend, non-Hispanic Black is in the light blue or gray. Non-Hispanic white, the general population, is in the dark blue. Other two minority populations, self-identified non-Hispanic Asian and Hispanic of any race, are in the green. The bar that I made across the top is the Million Hearts goal. The Million Hearts is a collaborative effort across all of the various government agencies, CDC, National Heart and Lung and Blood Institute, that we should control blood pressure rates to at least 65%. You see none of the populations make that red bar of 65%, but in the self-identified minority populations, the rates are lower. So here's a potent prevalent risk factor worldwide, including the United States, directly related to mortality. Mortality rates are slowing, but this risk factor is poorly controlled in all populations, but worse control seen in minority populations. Then you have a risk factor that is not only poorly controlled, but highly prevalent. Again, the legend, the gray bars, or blue, would be non-Hispanic Black. It stands like a tower above the other populations in the rates of hypertension. This is a very high-risk population. This is not, it is important for social sciences, but I was going to say this is not a social science factor, but it is a social science factor. But from a health factor and a public health factor, one of the things that we identify is that if you look at hypertension as a cause of death, the top bar is non-Hispanic Blacks compared to both Hispanics and non-Hispanic whites. The death rates are twice as high. That brings us to the design of the study. We use self-identified race ethnicity, not necessarily based on genetic markers, but the phenotype of patients who have poorly controlled hypertension, who have obesity, that predicts an increase in risk. The patients were randomized after a 2-week washout. The reason for the washout is to see when you place the patients on the medication, what would be the benefit. Now, one of the criticisms would be you may want to wash out patients for a longer period of time. But we were concerned when you look at the blood pressure levels that the patients had at the entry into this particular trial, that if we'd washed them out for 3 to 4 weeks, we would have had accelerated hypertension and maybe some patients who had adverse events. The other thing that you will note is that for the first 2 weeks, they were all placed on monotherapy with Foribostat in an open label manner. To those who are not knowledgeable about the science of blood pressure, it may be perceived that you should do a placebo control to show a benefit. However, we met face-to-face with the FDA, and they suggested that in a biomarker which has been shown to have such a powerful effect, that if you lower blood pressure in a very definable manner, there is no need for a placebo, and in fact, the placebo would place the patients at unnecessary risk and would give no further information on benefit. After 2 weeks at 250 milligrams twice daily, patients were then continuing on that dose, the third box at the top, or if the blood pressure were not controlled at greater than 140/90, Foribrestat could be increased to 500 milligrams twice daily. The acronym in the box, the third box at the bottom, AOBP, is important. It's spelled out at the bottom. It's automated office blood pressure. This is not the type of blood pressure that most of you have had when you visit your doctor. You walk in, they rush you in, you're talking, walking, they grab your arm, it's dangling, and they check the blood pressure and mumble something and walk out. These are patients who are seated for at least 5 minutes, feet on the floor, arms supported at heart level, 5 measurements, averaged, and that particular approach was used in the SPRINT trial, which is the US trial that showed the benefit of intensive blood pressure reduction, and that particular approach has been accepted by the Canadians as the appropriate manner to measure blood pressure. The reason that's important is because automated office blood pressure, the technique that we use, is seen as a surrogate for ambulatory 24-hour daytime blood pressure, and therefore is perceived as being a valid means of measuring blood pressure load. For the last 4 weeks, the 3 boxes continue on 250 twice daily, 500 twice daily, and for reasons of safety, if patients had blood pressures greater than 160/100, the bottom box on the left, 25 milligrams of hydrochlorothiazide was added. Hydrochlorothiazide is a very commonly available blood pressure medicine. It's in all the guidelines. It's relatively mild in its effect. We could have used a more potent agent, but the purpose was to keep the patients at a safe level, but not to modulate their response to Foribrestat in a very undue manner. Who are these patients? I've done multiple blood pressure studies, and I will tell you the dirty little secret is with newer agents in the past, you often choose those patients who have milder forms of hypertension, who are easier to treat, to show benefit. And then you could say, we have a new drug that shows that it lowers blood pressure, staying away from those more difficult treatment patients, including minorities. We did the opposite. In this particular study, we purposely enrolled a high-risk, diverse, difficult-to-treat population. These are the mean population values. Age, 67 years of age. Self-identified minorities, over half. Blacks, 37.8%. Mean body index, 33, obese. 65%. Persons with diabetes, almost a third. And then look at the blood pressures level themselves at the bottom. These were not easy to treat blood pressures in which you could show benefit in getting the patient's blood pressure lower. The mean systolic blood pressure, 153.9. The mean diastolic, 91.5. Let me say something about resistant hypertension and why it's important. This is a scientific statement from the American Heart Association. This was published in October of this year. Our late breaker trial was reported at the American Heart Association, so this paper was available at that time. And this particular paper suggested that we have suboptimal treatment of hypertension, that less than half of patients are controlled. The third bullet, that antihypertensive medicines are not maximally used in most patients. And the last bullet, those patients who are likely to have an optimal regimen but still be uncontrolled, including Black patients, patients with diabetes, chronic kidney disease, and coronary heart disease. So on the basis of that particular cutoff, they estimated approximately 13% of the adult population has resistant hypertension. As most of you know, the new guideline now is 130/80 versus 140/90. 140/90, the older guideline, was somewhat of an arbitrary cut point. The outcomes data indicates that if you wait for 140/90, your blood pressure risk is twice that than those persons who have normal blood pressure. So the last bullet, the estimates using the newer 130/80 will add another 4% of patients who will be defined as treatment resistant. The prognosis is not clear in all patients. The last bullet at the bottom, however, the risk of myocardial infarction, stroke, end-stage renal disease, and death with resistant hypertension may be 2 to 6-fold higher than that of regular adults who don't have resistant hypertension. And this is directly from the guideline. So our patients included a large number of patients who had comorbid conditions. We need to do an ASCVD risk calculation. It's not available at this particular presentation. We have a full paper that we're going to try to submit to one of the leading journals, either the Journal of the American College of Cardiology, but probably Circulation. Circulation is the leading journal of the American Heart Association, but the American Heart Association already accepted this, and it was presented by myself as a late-breaking trial, so we think Circulation would be the journal that would receive these particular data. Uncontrolled hypertension, therefore, is a problem. The dark blue at the top, we have to make sure that we're not dealing with pseudo-resistance. In this particular study, we did not. We used the appropriate blood pressure technique. We ensured that the patients had adherence. In clinical trials, people usually do adhere. They get a lot of love, a lot of attention. Sometimes they're reimbursed for their time and travel. But in conventional medical practice, poor adherence is a serious problem. And then white coat hypertension are patients who don't really have hypertension. Using the technique that we utilize, we think we were able to rule out white coat hypertension, and these were patients who may be truly resistant. Here's the technique. I already described it. I will not go again through it in detail. But to ensure you, one of the reasons the FDA allowed us to not have a placebo-controlled is because they perceived that we were using a technique which was valid and that indeed showed appropriate lowering of blood pressure similar to that seen with 24-hour ambulatory blood pressure. This is the algorithm from the paper on resistant hypertension. In the interest of time, I'm not going to go into great detail. If you have any questions about this treatment algorithm, I can do it later. The general principles, therefore, is to identify patients who have hypertension, to exclude secondary causes, to use the third bullet, mechanistically complementary agents. Those include long-acting calcium blockers, blockers of the renin-angiotensin system, and a diuretic, recognizing that ACE and ARBs as first step, especially in blacks, have not been perceived as being as effective. But in this particular trial, we did not treat to target. We did not put patients on these multiple medicines. We only wanted to show the effect of first step with faribrostat, especially in a higher risk population, since ACE inhibitors and ARBs have not been deemed as effective as monotherapy in black populations. Thank you very much.